Hi everyone, and welcome to our module on Wolff-Parkinson-White syndrome. Wolff-Parkinson-White, or WPW, is a cardiac electrical condition named after the three cardiologists who discovered it in 1930. This is a classic EKG of someone who has the WPW syndrome, and what you should notice is that there are P waves before every QRS, but almost as soon as the P wave ends, the QRS complex begins. There is a very short PR interval. Normally there's a P wave and then a brief flat portion of the EKG before the QRS complex begins, but in this case the QRS complex begins almost immediately, and that is characteristic of WPW. One of the key findings is a short PR interval. The other important finding is the delta wave, and I've zoomed in on it here so you can see it. Notice that right after the P wave, there is a portion of the QRS that's sort of at a different angle from the rest of it, and this is called a delta wave. And this represents early activation of the ventricles over a bypass tract. An electrical bypass tract that bypasses the AV node is characteristic of the WPW syndrome. So short PR intervals and presence of delta waves are the classic EKG findings of WPW. To understand the mechanism of the WPW EKG, let's review the electrical activity through a normal patient's heart. Normally the SA node is the pacemaker and it sends electrical activity to the atria, but the electrical activity can only spread to the ventricle through one pathway. It must go down the AV node, down the His bundle, and into the left and right bundle branches. In a patient with WPW syndrome, they have an extra piece of tissue called a bypass tract that is capable of conducting electricity usually in both directions from the atria to the ventricle. As a result, electrical activity gets to the ventricle in two ways. It'll go down the AV node the normal way, but also over the bypass tract. And this conduction over the bypass tract is what creates the delta wave. It creates an early deflection before the normal conduction down the AV node begins to generate the normal QRS wave. You can be asymptomatic with a bypass tract and it can just be picked up on your EKG, but a problem with it is that some patients will develop tachycardias. So I've shown the two types of tachycardia that can develop. They're called AV reentrant tachycardias. Note that this is different from AV nodal reentrant tachycardia, which is a different condition that I discuss in another module. This is AV reentrant tachycardia, or AVRT, and it can happen in two ways. Electrical activity can go down the His bundle and the bundle branches and then come up the bypass tract to the atria and then go down the His bundle again and up and back around, and this can create a large circuit with a tachycardia going at too many beats per minute, giving the patient palpitations and symptoms. The other possibility is that the electrical activity can go down the bypass tract and initiate the ventricle abnormally, and then that activity can spread back up the AV node and His bundle to the atria and then come down again. In this condition, because the ventricle is being activated in an abnormal fashion, not through the His-Purkinje system, it will be a wide complex tachycardia. We call this type of arrhythmia antidromic, and we call this type of arrhythmia orthodromic. Ortho means correct, so this is going correctly down the AV node and then up the bypass tract. This is anti, for opposite the normal way. It's going down the bypass tract and then up the AV node. I don't know that you'll be heavily tested on whether you can understand ortho and antidromic tachycardias, but you should understand that the presence of this bypass tract sets someone up to have arrhythmias. Now, if you have a bypass tract, as I said, many patients are asymptomatic. Their EKG shows a delta wave, and it's picked up incidentally when an EKG is done for some other reason. We call these patients having the WPW pattern. Those who also have tachycardias, which means they usually have palpitations, we say have the WPW syndrome, and they can have that arrhythmia I just described for you, AV reentrant tachycardia, either anti or orthodromic. And usually the treatment for these is to surgically ablate the accessory pathway, which means to zap it with a little heat or electricity so it doesn't conduct electrical activity anymore. The one thing you do need to know for your boards about WPW is that atrial fibrillation in WPW can be life-threatening. So why is this the case? Well, remember that in atrial fibrillation, the atria are depolarizing at a rate of 300 times per minute or more, and if all these impulses were to be conducted directly to the ventricle over the bypass tract, this could cause ventricular tachycardia and cardiac arrest. So atrial fibrillation can be life-threatening. And so in atrial fibrillation with WPW, if you slow conduction through the AV node, you will send more impulses across the bypass tract, and that can potentially cause ventricular tachycardia and cardiac arrest. So all these medications which slow conduction in the AV node are bad in WPW, medications like beta blockers, calcium channel blockers, digoxin, and adenosine. We use all these commonly in patients who have AFib without WPW, but in WPW they are contraindicated because they will direct more electricity over to the bypass tract and the ventricle, and that can cause cardiac arrest. The management of atrial fibrillation in WPW is highly complex. It's not something you're likely to be asked about on the boards. It's more of a cardiology board question. We generally try to perform an electrical cardioversion and shock the heart to get it back to a normal rhythm. If we can't do that, we use antiarrhythmics like procainamide or ibutilide. But again, this is a highly advanced topic that you're not likely to be asked on the boards. And that concludes our module on WPW.